Okay, thanks a lot for inviting me. And it was great to hear, I think the previous lectures, and especially going into what I'm going to be talking about, thinking about the ethical considerations. So I should say at the start that I am an end user, as was discussed, and I think I've had 5 years of experience in the U.S. doing precision oncology. I ran an institute there. We haven't done 150,000 cases, but we have done around 1,500 cases of advanced cancer, and I hope that during the course of what I'm going to present, that I'll give the use case, at least for advanced oncology. So it's different than early oncology, and hopefully I'll make a compelling story. Again, I'm not an expert in the area of data security, but we're end users, and I have worked in New York State, which is a highly regulatory compliant state, and all of the tests that we use clinically were basically at the level of FDA approval. So, I think it's important to think about the specific use case. Particularly, I'll talk a little bit about our driver project, which is an SPHN-PHRT project. I'm not going to go into great detail, but I want to just give you a little bit of a feel of the project, and I listed some of the individuals here. The project that we have is really motivated by the idea that targeted immunotherapies work, but there's resistance. And in the field of immuno-oncology, one of the great exciting observations in melanoma, and lung cancer, and other cancers are that some patients respond dramatically and others don't. So part of what we'd like to do scientifically, working with the co-leaders of the project, is to understand this resistance. In order to do that, we felt that we needed to set up a program where we would have consistent genomic data, and the data will be uniform across all of the sites that we'll be working in. It will not replace the current systems at all the local hospitals, but it will require that we're going to do a lot of data shift. And we're also going to combine that with functional assays from the patient's material, which represents potentially another problem. So I wanted to list some of what I thought are some of the key issues and just something you should be aware of. So we are really responsible for maintaining high-quality clinical care throughout the process. This is not research, this is clinical care that we're responsible for. It's not related to the SPHN or PHRT project, but it's part of our clinical care. For advanced cancer, we have very few options, and so this may get into constraints related to ethics. I don't think the ethical framework changes, but I do think we have different considerations, and I'll give you an example. The genomic data that we use regularly is in what we refer to as a secure environment in the hospital. You're experts in data security. You may not agree with how safe it is, but nonetheless, we view it as safe. And the comment I would make is that, just like a bank, you can steal data, you can go to a store and steal things, but there are laws and there are regulations. So if you are stealing data, we at least have a social framework where that's not acceptable behavior. But nonetheless, it's not a perfect system. And then, obviously, we're going to be thinking about new genomics platforms for clinical use and research, and how do we share the data. And Gunnar Retsch will be talking later, is one of the leaders in the co-leaders with me in the project, and he's going to really put a lot of effort in coordinating that. Genomic data obviously has implications not only for the patient but for their family, and this is something, especially in cancer care now, that we have to think about. And then finally, and I think very importantly, we have to give consideration that there are both academic settings where we share data and want to share data, and there are also commercial settings where we share data, and we want to develop new drugs, and the only road to doing that is finding a partnership with a pharma company or a biotech company. And we could have a long debate about that, but that's really, at the end of the day, that's what we need to accomplish. I often view and present the precision medicine in this format because it's not just about the genomics, it's about maintaining all the data. And probably the greatest insights from precision medicine will come through coordinating all this data. When we define precision medicine, there could be a number of definitions. I just think that one of the important things is we're thinking about not developing a personalized treatment for an individual, but identifying the right treatment for that person at the right time. And that's critical. We all know about the exploding use of data. I think, I'll just skip ahead. I want to use this framework, again, similar to the wheel, to emphasize what we're trying to do. In real time, we're trying to move forward and identify patients, so diagnose them, treat them, and then improve the healthcare. And this is something that's going to take many, many years to do. So I think one of the differences from a lot of the genomic studies we've done in the research setting is that there's probably a lot of exposure for data to be leaked. A lot of data will be processed over time if we're doing this correctly. And hopefully this will lead to a more efficient system. We also have concerns about small data, which I won't go into any detail. Clearly, there's small data that may be valuable in the precision medicine setting. And then finally, we'll have to weigh the value of collecting this data. And this is sort of a general comment, and I think it's well known to most of you. For the economic concerns, this is obviously very important for whether it's Switzerland or the United States or other countries, thinking about the heavy cost of medicine, the heavy cost of introducing more framework of, and foundation for precision medicine or personalized medicine, and then thinking about maybe some of the other features. Now, I think what's important, and it's highlighted by Harold Varmus, who was formerly the head of NIH, the head of NCI, and also Memorial Sloan Kettering. And what he was arguing is that we need to gather this data, whether it's in cancer care or other care, in order to improve efficiency, but also to make the best argument that what we're doing is useful. So just a little bit of specifics related to precision oncology. Precision oncology here, as I'm showing here in this field, will relate to the genomics, but also some of the model systems that we'll develop, and then and some drug screening that I'll just briefly discuss. So in a program like this, we think about how we can improve the setting of oncology care in the clinical setting, whether it's in clinical trials or standard care therapy. I think they've uploaded the old slide set that I had, but I wanted to just tell you about an email that I received this morning from a patient's doctor who was requesting that we help them with precision medicine. And the request that they had was, he's a 39-year-old patient, he has metastatic renal cancer, he's failing all therapy, they're trying immuno-oncology, he has 3 children, really nice guy, can we do something? And there are a lot of concerns with that. We probably can't do anything. We may not be able to do it in a timely manner, but we certainly would like to try for that patient at the great hope that maybe we would find something, and it's pretty rare that we would, but then also that maybe we would learn something for the next patient who presents like that 2 years from now, or 3 years, or 5 years from now. That's a compelling story, and I call that precision oncology 24/7, because this is the type of scenario we're presented with all the time, and we need to have a framework where we can do this. The framework that we set up in New York and that we'll be setting up as part of the project will be more extensive. We'll be doing sequencing of both tumor and normal, so we'll have information at the germline as well as patient somatic tumors. And it'll be based on exome sequencing, but we're hoping to also do whole genome sequencing. There's a number of types of sequencing that's required for clinical care. We won't go into the detail, but it's based predominantly on setting. And one of the goals of our project will be to interrogate all this type of data and integrate it. And we'll be using different platforms. This is just an example of one of them, and hopefully working with some of the other bioinformatics groups. A lot of data sharing, as you can imagine. We'll be sharing data through portals, but then also through reports that will be generated. So these reports will be used in the clinical setting, and that's, I think, important. So we'll have clinicians who will be looking at the materials, we'll have oncologists and others, and part of the partner oncology program will be doing clinical tumor boards to discuss patients. So we have to find a way to present data and share data. Surprising to some, but there's a group that's going to focus on variants, and one of the things that's probably surprising is that in oncology, some of the variants that we describe are not really well described, and we don't call them clinically because we haven't seen them before. So one of the goals is to create a knowledge database across Switzerland, maybe internationally, and it would be based on one that depicting here. There are other examples that have been developed, and this would be for the greater good of cancer care. We also are going to further develop the CBio portal, which is a portal that allows us in what we think is an anonymous way to share data about cohorts and looking at individual cases that are identified through research identifiers. And Gunnar is going to be leading that development for our program. And I know that in Lausanne and other places that we're using this platform. This represents a really good way of sharing data and allowing us to ask questions like, what percentage of our patients have certain mutation configuration? We can drill down to individual patient level. And obviously, this has to be done in a way that we can share data. In our program, which, as I mentioned, have around 1,500 cases now of advanced cancer cases. These are patients, as I mentioned, with no options for standard of care, and now are looking for other options. We've sequenced them and have found, for the most part, that we really don't have targetable lesions, so we have to find other ways and other approaches. We're thinking of informatics approaches, looking for potential opportunities for immuno-oncology using the informatics that we have. And for our specific project, George Kukos in Lausanne is going to be working with us to develop some functional assays that will then combine with genomics. The data will be presented in different formats. I put this as sort of a controversial approach, which is how much of the data do we make public? There may be reasons to put the data in some format publicly, but certainly for our clinicians, we want to make the data available. And I think some of the better examples are, a clinician who takes care of patients with bladder cancer would like to know why this patient responded to immunotherapy and another patient doesn't. And they could quickly look at their personal cohort. But for example, in an organization like Memorial Sloan Kettering, where they've done 10,000 cases, certainly there's a lot of information. What happens if we multiply that across all the cancer centers? Obviously, data will be available in different formats, and how do we protect this? I think very, very importantly, we should be generating patient-derived materials, whether it's xenografts or organoids. This is just an example of work that we published in this area, and it's leading to our ability to nominate new drug candidates. So this is certainly in the research area, and hopefully through projects like this, or through projects where we are able to do drug screening, we can nominate new drugs for therapies. But again, these reagents are coming from patients who are still alive. They may not have long to live, and we're trying to answer the question very rapidly. These reagents then remain even after our patients die, and so we've had some very compelling stories where we have patients who die. We were not able to treat them in time, but we do find combination therapies, and so this represents an important consideration. As I mentioned, our project will be also trying to think of ways to take the genomic data from hospital data and try to uniformly analyze it so that we can have one data set. Now, as I said, this will be done in separate institutes. There'll be other groups that will be thinking about ways of doing this. So we want to work together to come with some uniform large data set that we can work with in a research setting. And we hope it'll inform us how to deal with this in a clinical setting. And one of Gunnar's, I think, challenges will be to make this data available in the way that people like Gunnar and other computational biologists want the data, which is in a way where they can analyze it. So we have to figure out ways of doing that. And this is just a schematic from the graph showing the interactivity with other entities in Switzerland. So just to finalize, I think in New York we had a lot more complexity and heterogeneity than I see in Switzerland. I think in Switzerland we still have heterogeneity of language, obviously. We have very different systems, and we're going to have to think about a way of coordinating all the data. So just end on this slide, if there are any questions, but just reiterate some of the important points that I think are worth discussing in the use case of oncology. So thank you very much.